thank you very much for those kind words, and thank you for being here this evening. For those of you who've travelled from Wales and don't know it's World Kindness Day, so that means no heckling, okay? Deborah's already given an introduction to what psycho-oncology is, but I'll just say it again. It's a relatively new subject area. It's been around for about 45 years, so we're talking about the early 1980s. That's when it became recognised as a discipline by itself. And it examines the impact that cancer has on patients, their families, but also it looks at how working in that environment, so working with patients with cancer, how challenging that can be for the healthcare professionals, the doctors and nurses. As you can imagine, it's a very emotional subject and you can get quite burnt out when you're working in that area. It is across many different levels, so we're looking at emotional aspects, psychological aspects, and all stages of disease. So when we're talking about our psycho-oncology research, what we do is we work with the patients and their families, and we work with the healthcare professionals to identify what the problems and challenges are for them when they're going through their treatments and care. And then we try and develop an intervention that we hope is going to help. And it's all very well having a good idea that you can think of that's going to help improve quality of life, for patients when they're having their treatment. You have to evaluate it to make sure that it really will be useful before you can put it out there into clinical practice. Now, I've been working in this area for a quarter of a century. Sounds much longer than 25 years. And I've covered lots of different areas of work. But this evening I thought it would be useful if I chose two quite different topics, so you can see the sort of range of work that we do in psycho-oncology. So for the first part, I'm going to talk about the interventional work, which is to help patients understand and healthcare professionals explain randomized trials of cancer treatments. And the second part is going to be about examining the effects that breast cancer treatments might be having on cognition, so that's on memory and attention and thinking. So I'm going to split it into those two parts. But before I start, I thought it might be a good idea just to tell you where I'm from if you can't hear any accent, because it might have gone by now. So I'm from Wales, so I'm the youngest of 5 children from a small town in Wales. But I'm going to take you back to 1977, when I was 17. And I went off to do some orthopedic training. So I went to the Bright Lights of Cardiff. And that was a 2-year course. And when you finish it, you could either do physiotherapy or you could go on to do nursing. And I went and did general nursing, so state-registered nursing. Now, back in that time, so 79 and 80s, cancer wasn't really talked about, not like it is today. And there were lots of incidences when I was on the wards where relatives were being told the diagnosis of cancer before the patients were being told the diagnosis. And sometimes patients weren't even told the diagnosis. So you can imagine what a challenging situation that was to work in. But at the hospital I worked in, we had this visiting oncologist called Dr. Keith James from Valerie. And I was so impressed by the way that he was communicating with his patients and talking about treatments, which was something completely new from the other clinicians I'd been working with, that it just seemed to naturally be that I would then move to the cancer hospital, which is Valerie Cancer Centre in Cardiff, to do the work there. So I was there for a few years, about 3 or 4 years, and then I moved to Brighton in 1985, and that's when it had 2 piers. Now, when I told my parents I was moving to Brighton, or moving to England, my father gave me this book, Talk Tidy. And I have to say, I've been trying to talk tidy for the last 30 years. So Sussex is very close to my heart because I did my undergraduate degree here in experimental psychology. And here we are. It was a small group. There's only about 30 in the group. And we have Pete Clifton, who is here, and Alan Garnham, who is still at the university. And I'm in here somewhere as the mature student, you see, with all these young ones. Now, I hadn't, left cancer behind at all. My final year thesis was personality, stress and cancer. Is there a link? And 30 years on, we're still asking the question. And I've been working, we did some small group work with Melanie Flint over in Brighton Pharmacy. And where we're looking at whether if you reduce stress with a stress intervention in women having chemotherapy treatments, then maybe the chemotherapy will work more effectively. So we did some small work there, and hopefully we'll get a grant in December to follow it up. Now, following that, I didn't go far. I did my first piece of research at the Royal Sussex County Hospital with this breast surgeon, Malcolm. So it was with Brian Hogbin, who was a consultant breast surgeon there, and he had taken part in some communication research with Leslie Fallowfield, where he was taping the consultations for her to analyse. But Brian, he's a great trialist, and he decided that when you're given the news that you have cancer, you often won't hear anything else during that consultation. So he decided that he would give these audio tapes, so they're personalised audio tapes, to his patients, and then they can take it back and play it to the family. So, and that's all very good, but of course you have to evaluate whether it really is useful. And so my first piece of research was trialling whether it worked. By some of the women received it and others didn't. And in fact, it was a good intervention, and some people are still using it across the UK and in Sussex as well. Then I came back to Sussex and I did my DPhil in neuropsychology with Alan Parkin, who's unfortunately he died a little while ago now, 1999, too early. And I was looking at memory and amnesia. And it was in two clinical populations. It was ones who were head injured and others who had chronic alcoholism. And the reason I'm just bringing that up because it'll feature later on in the work that I've done. So I thought, well, here we are, 1996, that's 10 years on now from coming to Brighton. And at that time, so psycho-oncology was still a new area, but there were 5 or 6 units in the United Kingdom, 2 of which were in London. So I thought, well, I must get myself a position in one of these units because I'm still interested. I was hospice nursing all the way to supplement my income on the grants in those days, so wanted them both together. So a position came up in Leslie Fallowfield's group at UCL. So I went along, I thought, right up my street, tape recorder, I can do that. It was tape recording interviews with women all across the UK. Well, I didn't get the job. So I thought, right then, well, I'll do what you normally do. I popped over to California to join my pals out in California and soak up some sun. And while I was there, I thought, well, UCLA, I'll pop along there and see, there's a lot of popping going on, and pop along to see this medical oncologist. So this is Dr. Patty Gantz, and she's a breast medical oncologist, but she had an interest in psycho-oncology. So I said to her, are there any positions going in UCLA? And she said, you need to go work with Leslie Fallowfield. So I thought I've just tried to work with Leslie Fallowfield. Anyhow, another position came up, and it was before you had, Instagram and all of that, so it was a letter came through, and I ended up working at UCL. So that's how I got into the area, and I've been working in this area ever since then. So back to some of the research that I've done. So the first part I'd like to talk about is this talking about randomized trials of cancer treatments. And because some of you in the audience may not be familiar with how a new drug or treatment comes about, just briefly, simply explain. So when you have a new potential new treatment, it has to go through a phase 1 trial, first of all, to make sure that it's safe. So it's going from the lab into humans. And if it passes through that part, then you move into the phase 2 trial, and that's seeing what the best dose is and what the side effects are. And then if it goes through that part, it'll go into a phase 3 trial, which are usually randomized trials. So you'd have your potentially exciting new drug or treatment versus what the current gold standard treatment is. But talking about randomized trials is quite difficult because there's a lot of complex language involved. And they can be of different sorts. So you can have a treatment or medication versus no treatment, watchful waiting. Or you can have a treatment versus a sugar pill, a placebo. And patients are randomized to these different treatment groups. So it might sound a complex way of doing something, but it is a safe and scientific way, really, so that at the end of the study, you know that any differences are due to the treatments, not because you've got such different people in the groups. It's not due to the groups. Now, in London, this is Professor Robert Suhami, who is an eminent oncologist and has retired. And he was really concerned because back in 1996, fewer than 5% of eligible patients with cancer were going into the randomized trials. And the concern is because if you don't have the patients going into the studies, then you're not going to get these really potentially great new treatments out there routinely in clinic. So when he talked to his colleagues, they said, oh, no, we try to talk about these trials of patients, but they're very reluctant to take part in them. So my job then was to find out what all the challenges and the barriers were to taking part in the trial. So start with looking at the patients, Right, the doctors are saying they don't want to go into it. Let's have a look what the patients think. So actually we found that patients thought it was a really good idea that they should be invited to take part in medical research. Very good idea that they should be invited to take part in a trial considering 2 different treatments. When you mentioned taking part in a randomized trial, then you tended to lose about 50% of the patients because they thought it was really risky. You lost more women than men. Men tended to be less risk averse. But when you gave them the further information about, ethically, you'd be told all about the treatments, it's voluntary, all the things that you should do. Actually, 85% of patients said they would consider taking part in randomized trials. So we could say, well, actually, it isn't the patients who are reluctant. Perhaps it's the doctors are reluctant to discuss them because it's quite complex language that you have to get across to patients. So the next thing was to talk to patients and find out that from those who had agreed to take part in a randomized trial, the main reason they went into it, and for those who declined, why they declined. So people said that they entered trials to help other people in the future. That was the main reason. And those who declined the trials, they were worried about randomization. They really didn't like the fact the doctor couldn't choose the treatment for them. But even 51% of those who were in a randomized trial didn't like the fact that it was a randomized trial. They really would have preferred the doctor to choose. So I thought, well, let's see then. So we've got all of this. What's going on? So with the trusty tape recorder, this is a cassette tape recorder here, I have to say. I think they're coming back into fashion. I went around and recorded almost 300 actual discussions, and this was in London and some in the southeast, of different trials. So we had placebo-controlled, chemotherapy trials, all sorts of trials, and it was 15, and these were senior cancer clinicians or senior surgeons. And what I was listening, when I listened to them, what I was finding is that very few actually described what randomization was. They would tend to say something like, so I can't make the decision, I can't make the decision, and you can't make the decision about which treatment to have. The treatment will be chosen at random, rather like tossing a coin, or rather like pulling a name out of a hat. And you can see that this is quite a sort of risky element to it, especially in the context of life threat, which cancer is. But also 83% of patients didn't have their understanding checked, so you wouldn't know what information they'd taken on board about that clinical trial to be able to give an informed or an educated decision about taking part or not. So there really was, a need there for an educational intervention. Now, I had a lot more energy in those days because all of that body of work took place within 3 years. So I was all over the place there, but very speedy. So we needed to get this intervention in place, and the doctors agreed as well. So what we did is we developed an educational program called Communicating About Randomized Clinical Trials. And what we wanted to do is for this program to enable healthcare professionals approach patients who are eligible for trials and feel more confident about it, and then be able to structure the discussion about a trial and improve their repertoire for describing randomization. And that way we get more educated decision making for the patients to decide really whether they wanted to go in or not. So we had patients, these are 5 patients that were on the first, called a consumer liaison group. And so they were all in trials themselves, and they gave us a lot of information to help us develop some scenarios. The first batch, we had 6 scenarios, and the patients are actors in these scenarios, but the doctors are real, and there's one in the audience tonight starring in our first batch of videos. So the doctors talked about a trial that they were recruiting patients to. They're about 20 minutes long. It's not like Holby City, so they're not scripted, it's all improvised. And the doctors were very kind because they let us use however they performed on the day, because these are meant to be not the best way to talk about recruiting patients to trial. They're meant to be used as trigger tapes in small groups. But as I said, it's all very good, well and good making a nice glossy package. We like to know whether it really will change communication. So we evaluated it. So for the evaluations, we ran 10 small group workshops, and we filmed the doctors and nurses who came on the workshop. We filmed them talking to an actor patient about an actual trial they were recruiting people to. And they did this before and after the course. They also completed some questionnaires just saying how confident they felt before and after the course. And researchers who didn't know which time point that these videos were taken also scored them on their key points, shall we say, that they were getting structure in the interview, they were describing randomization, they were checking understanding so that the patient knew what they were talking about. And we had a huge, significant results. They felt more confident talking about trials, and they were more competent. And we had a great statistician who did some of her PhD, Yvonne, who's in the audience tonight, because she had to build a separate model to be able to analyse the data. So we made 6 further scenarios covering different sorts of trials. And then we trained doctors and nurses to facilitate the material so they could just roll it out, which they did across the UK and also worldwide. And there's a comprehensive facilitator handbook that they can follow to make it easier for them. Now, Wales have always been a great supporter of our work, and they continue to use all the materials we've made. And in fact, Barbara Moore and Libby Batt have been champions of this, and they sent through, this is a while ago, a graph to show how their recruitment to trials had increased following training. Of course, there's lots of other factors that go on. So you're looking at the red line, which is zoomed up for them since 2005. There's lots of other factors going on, but they wanted us to take some credit that what the training had done was make them think about every new trial that came on board so that they could plan how they were going to talk about the trial and recruit patients, so they felt more confident. Now, just popping back to this one, because that's phase 3, and the doctors and nurses said, well, thank you for doing that, but you know, the phase 1 and phase 2, which are early phase trials, can be even more difficult because these involve palliative patients. So can you do something about that? So we did a similar package. We did a lot of recording interviews, actual interviews about phase 1 trials. We interviewed patients as well to find out what their understanding was, what the challenges are. And we evaluated it again in small groups and looking at objective and subjective measures. And again, as Yvonne, we found we had excellent results. So it was making a change. They were changing their communication. Now, there we go, little Welsh dragon appears again, because actually it isn't just one doctor or one nurse that talks about a trial. You've really got to have a committed team of clinicians, well, from the histopathologist all the way through. You have to have a whole team, and we had money. This is a 5-year program where, unfortunately for Leslie, she had to go to Wales once a month to run some courses. But I was quite happy going up there and collecting data because we wanted to find out what the challenges were. And it was all sorts of cancer teams. So it was colorectal, gynecological, breast, hematological. And you might think I've got a bias for Wales, but Wales was chosen because it was smaller and it only had 3 networks. So it was going to be simpler for a statistician to do the analysis. At that time, I think England, there were 34 networks, so it was too complicated. And we followed it up with some team training. Now, at the same time, we wanted to work back with the patients again, because I don't know if any of you have ever seen any patient information leaflets about clinical trials, but they're really getting so thick and complex. And we know from other research that only 1/3 of patients will read them cover to cover. So we wanted to do something that would help complement it by making patient information films. So for these films, they're available. Well, we started off on DVDs, but actually, you know, they're on the web now as well. So you have it broken down, so it complements what's in the information sheet, because legally you have to give all of the things, and ethically. But patients and the family can revisit different aspects. And so, for example, randomization will be a graphic, just to make it easier for them. But we had a lot of feedback from patients to say what they really liked is the question and answer session. So this is where you have patients and members of the public who've read through the information sheet and are coming up with questions that patients feel maybe they think they're too minor to ask the clinician, you know, when they're talking about the trial. So they really found that useful. But we also had, it had a knock-on effect because there was this clinical trial, prostate trial, which was organised with the Medical Research Council. And they said that they found them useful. It's not just the patients it had helped, but it also helped some clinicians to understand what the trial was about. And also to use it as a guide on how they should present the trial and structure it. So it's got a good knock-on effect as well, especially for trials that you know are going to be challenging. So that might be a bit of a whizzy way through the randomised trials part of it, but I want to go on to talk about something called brain fog that quite a few of you may have heard about, because my DPhil, or PhD, was in neuropsychology. So I had an interest in that. And while I was working in London, so this is the mid-90s, 99, there was a lot of women complaining or reporting problems with their memory or attention when they'd had breast cancer treatment. So you had a wide range from 25 to 75%. There was a lot of reporting high levels in the States as opposed to the UK, but it was still there. And the sort of problems they're talking about were word finding problems, lack of concentration, unable to multitask, which is similar to women going through the menopause as well. So it's similar sort of things. And there was a suggestion that maybe it was a drop in estrogen because the breast cancer treatments can cause this drop in estrogen. Or in some cases, maybe it was effect of the chemotherapy itself on the brain, or maybe it was stress and fatigue. But when you do the objective tests on the women, you don't find this huge proportion who are having problems. It's very much smaller, and I'm going to just say a little bit more about that. So in London, in fact, Val Schilling, this is where you joined us the first time. And I've returned. So we did a cross-sectional study. So we were measuring women who'd been on hormone treatment or endocrine treatment for breast cancer. They'd been on it for 3 years. And we just measured their memory and attention and concentration versus a group of women, healthy control women. So we had one time point and we wanted to see what was going on. And indeed there was a little something happening with verbal memory for quite a few of them. So we thought we would take this further and had a grant with Cancer Research UK. And this is one of the first longitudinal studies looking at the cognition in women having breast cancer treatments. So we had 3 groups of women. We had healthy control women, we had women who were having chemotherapy, and women who were having endocrine therapy. And it was down in the south and also up in Manchester. We were working at the same time. So followed them for 18 months. So it was before they start any treatment, and then 6 months later, and then 18 months later. And we were finding, when we were testing them objectively, we were finding a mild impairment for a few women, mainly those women who'd had a treatment-induced menopause. So they were younger and they were thrown into a menopausal state by the treatments they received. And again, we were finding the problem in memory, verbal memory, and attention and learning. There were still many more women reporting problems, though, than we were, whether the test, we weren't picking that up with the tests that we did. And you can see that, you know, it is a problem. It does interfere with their quality of life. So, for example, this is at 18 months, following treatment. And this woman's saying that she has to take a lot of notes, and she knows that her memory isn't as good, attention, as it was before. She feels like she's sort of deteriorated. Now, at the same time, there was this IBIS-2 study. It was a great study to piggyback on to look at memory, because these women, these were postmenopausal women who were at high familial risk for developing breast cancer. And they were randomized, and it was to a placebo, double-blind, placebo-controlled sugar pills. So they didn't know if they were going to receive the sugar pill or the drug called anastrozole, and neither did the doctor. And that's great from our point of view when you want to measure something out there, because their performance wasn't influenced by knowing whether they were receiving the drug or not. This was a 5-year study, and at the end of this study we found no differences between the group that had received the sugar pill and the group that had received the endocrine treatment. And there was no differences in reporting as well of problems. So this was, great really. This is good news for the patients. But a colleague of mine, Kirsten Hermelink in Germany, said, Val, we're finding problems with the women before they start any treatments. A third of women were having problems on their tests that they were doing, on these cognitive tests before treatment. So maybe then let's have a look at stress and fatigue. There could be lots of things going on here. There's lots of causes of cancer-related fatigue. So different medications, emotional stress, the cancer treatments, pain. So just think about it. So if you have a diagnosis of breast cancer, that's very stressful. If you have surgery for breast cancer, that can be trauma. And if you have chemotherapy as well, you get lots of inflammation. And so all these stresses on the body, your body will react, and it produces these proteins called pro-inflammatory cytokines, they're called. And when you have an increase in those, then you have fatigue. And we all know that if you fatigue, it's going to interfere with your concentration and attention. And of course, that will have a knock-on effect and interfere with your recall and memory and everything. So not long ago, we did, it was a small study, Money from Breast Cancer Now, and it was to explore really whether the cytokines were linked to performance and self-reporting of cognition, and also whether it also showed up on brain imaging. And this was, it was Charles Zammit, the surgeon in Brighton. We worked with him, and we had Kevin Davis and all sorts. We had Mara from the imaging and Sandra from the labs here, whose interest is in cytokines. So it's quite a tricky one to do, because we wanted to measure women before they had any treatments, any surgery, and then again after surgery, and then again after chemotherapy at 6 months, or the group that didn't have chemotherapy, measuring them at 6 months. So for this small study, we did find, maybe surprisingly or not, that there was a rise in, these are 3 cytokines. This one you probably will have heard of, interleukin-6 you may have heard of. So we've got an increase in these cytokines, and it's shown, the example given is just on this, this one, but it happened for all 3. So at 6 months, the group of women who had had chemotherapy were having this rise in the cytokines. And this rise in cytokines caused fatigue. The fatigue correlated with them reporting problems, but we didn't objectively find any problems with them. Now, looking at the brain then, so these 3 cytokines are showing up here. So they correlated with these parts of the brain, and these parts of the brain in other conditions have been repeatedly shown to be linked with mood changes, depression, and inflammation. So if you have chemotherapy, this could be partly a reason why you're having these problems. You're fatigued. So there's a lot of different things that can make you have brain fog or feel like you have brain fog. We covered depression, anxiety, so it's moods, or is it low estrogen? I haven't talked about genetics. I haven't talked about the factor of age and IQ as well, because if you are older, you're going to be slower on doing your tests, your neuropsychological tests. A lot of the earlier work that's been published, they weren't taking that into account. Because when you take a lot of that into account, then you don't find those changes. But there's another aspect that I said that, well, we were finding with our tests that lots of people were having some problems hearing. So now these breast cancer treatments, the chemotherapy treatments, are not known to be ototoxic. There's other chemotherapy treatments such as cisplatin for different conditions where you do know there's going to be hearing problems, and they're managed accordingly. So with Rob Lowe, who's a consultant research audiologist in Brighton, and Sankham Mitra and Hazel, we just thought, well, maybe people aren't hearing it properly then, because they were failing on this auditory verbal learning task. Perhaps they're fatigued and it's taken a greater effort for them to attend, really, and if you don't attend, then you can't encode and lay down the memory trace. And your brain has, your auditory pathway here is full of estrogen receptors. So is it as simple as that? We know that a drop in estrogen is linked with something that's called a sensory neural hearing impairment. So what we did is the women who were in that 18-month study, the chemotherapy study, we had some volunteers who Rob tested. And so on this graph, this red line, these are women who had a treatment-induced menopause. So this is where their estrogen drops suddenly, and we find that at 6 kilohertz, their hearing has dropped to the level of a 60-year-old. So we thought, well, this is strange, let's try that again. So we did a small pilot study, only this time we had women who hadn't had chemo, so it was before and after. And again, here it is, there's this drop. And these treatments aren't known to be ototoxic, so we thought, well, maybe it is estrogen then, the estrogen levels have dropped and this is what's causing it. But our colleagues down in Southampton have said, oh, do you know, this interleukin-6, high levels of those are also causing sensory neural hearing impairment. So it could be a number of things that are happening. So, you know, why should we be interested in it? Many people would say you're still going to give the chemotherapy for the breast cancer. Why should we be interested in that? But these treatments aren't meant to be ototoxic. But a very good reason to be interested in it is that it's been shown, sensory neural hearing impairment has been shown to be the highest modifiable risk factor for dementia. So we really need to do further work to find out if breast cancer treatments are implicated, so that you can then at least talk to the patients. They can have a better idea and make a decision about which treatments they want, but also we can learn to manage the problems earlier. So there could be another link in with this aspect of brain fog, which it's really complex melting pot of lots of different things. And I'm hoping that get a grant with my colleagues in Brighton and Southampton, Keele and Belfast colleagues. We're putting in a grant to study this. We've tried several times to get a grant to study this, but lots of people don't think it's so important. But we think it's a very important aspect to look at. So that's the second part of that. Now, so I hope those two aspects have shown you the broadness of doing research in psycho-oncology. Of course, you don't do it all by yourself. And I've worked with lots of people, as I said, for 25 years. This is our current Shaw-C team. Now, we've got lots of people in here, administrators, finances, Leslie's there, of course, and research fellows. Now, Shirley, I don't know where you were when we had this photograph taken, so I've had to, where are you, Shirley? I've had to, I don't know where you were, so I've had to put you there. And we couldn't do without Shirley, because she's our programmer and our data manager that keeps us going. And Tracy, I mean, you had to make, you had to be here, you're retired, I know. But Tracy worked with us for 15 years, keeping us in order as the unit administrator. And down here, these are our independent statisticians who understand. We've worked with them for a long time. This is Yvonne Solis-Trapala, and this is Vern Fairwell and his son, Daniel Fairwell. They understand how to analyse our type of work. There's lots of people I need to thank. I've worked with lots of people in the past, and film crews, of course, and physios, and family and friends, and of course, my parents. I wouldn't be here without them. Well, at least my sisters are here. So I'd like to now hand over to Professor Malcolm Reid, Dean of the Medical School, to close the proceedings. Thank you.